ممكن نبدأ.
ايوه ممكن.
السلام عليكم. Welcome to our third journal club. I am Dr. Ahmed Amir Wahaballah. I will be the moderator of this journal club. This a regularly based monthly journal club that is being held by the Sudanese Consortium for Surgical Development, and we are glad to have you all here with us today. Uh, the theme that we are taking in our journal clubs is the surgical research during conflict. Our paper for today will be about this theme. It is titled Bringing Critical Emergency Medicine, Resuscitation, Trauma Education, and Training Back to Arm Lively Affected Communities. Why does the conflict in Sudan matters? Our team for today will be the presenter Dr. Hamdi Abdel Karim, thereafter Dr. Mariam
February.
Rashad,
ده انا اشوف بس 11 تطلع الصيف.
and Dr. Awad Osama, and Dr. Alaq Adil. Our guest speaker for this month's journal club is, and also the corresponding author for today's paper is Mr. Ayman Umar Nasr, who is a consultant surgeon and assistant professor in trauma unit, King Fahd University Hospital and College of Medicine, Imam Abdurrahman bin Faisal University in Khubar, Kingdom of Saudi Arabia. Mr. Ayman is also the editor-in-chief for the Journal of Acute Care and Resuscitation, and also he is the president of Human Resuscitation Organization. We are glad to have you today with us, Mr. Ayman.
السلام عليكم جميعا. It's a pleasure to be with you all.
Also, I would like to welcome our guests today uh, from all Sudan and outside the Sudan, our fellows, our colleagues, mentors, and seniors. Also, I would like to welcome Dr. Bahauddin, SCSD Research Officer, Research Department Director, and Dr. Nazar, SCSD Deputy Director of the Research Department, also our Chief Visionary Officer, Dr. Muhammad Al-Sadiq. In this journal club, we will talk about introduction, case presentation, the BICO framework, and paper demonstration. Also, we will compare the literature and the selection criteria for our paper, the current situation for research in the critical care, and also study designs and strengths and weakness, which will be presented by Dr. Miriam Rashad, and reliability and relevance of this paper, which will be presented by Awad Osama, and also the research gaps and future directions, which will be presented by Dr. Alaq. Also, we will have uh, an opportunity for questions and comments. If there is any question or comment, raise your hand or write it in the comments, and feel free to ask at any time. As I mentioned, our theme is the need for critical emergency medicine and trauma surgery within the conflict. The paper title is Bringing Critical Emergency Medicine, Resuscitation, and Trauma Education and Training Back to Tribally Affected Communities. Why does the conflict in Sudan matters? This a letter to editor, which was published in the in a peer review journal. which was published in European Journal for Trauma and Emergency Surgery and 2023. The Sudanese Consortium for Surgical Development is a pioneer is a pioneering organization dedicated in advancing the field of surgery in Sudan. SCSD was founded with a vision of achieving high-quality surgical care through education, research, advocacy, and public awareness, inspired by the legacy of the greatly missed Dr. Muhammad Abbas, our senior surgical registrar, whose passion and dedication to the field left an indelible mark on all who knew him. The SCSD is committed to carrying forward his vision and make a lasting impact on healthcare in Sudan, especially in the surgical development. The ongoing conflict in Sudan has created a catastrophic humanitarian crisis. According to the Sudan Crisis Report, 1 year of conflict, the healthcare system is near collapse, with a significant proportion of hospitals out of service due to violence, lack of supplies, and power outage. This situation, compounded by the breakdown of the healthcare infrastructures, has resulted in an overwhelming need for critical emergency medicine, resuscitation, and trauma surgery education, and training for care workers and lay people. Despite prior effort to improve training, the existing capacity is insufficient to meet the demands of the current crisis. Immediate action is needed to train medical personnel and provide essential supplies to address the rising number of trauma cases and save lives. This picture demonstrates small proportion of what our doctors in Sudan faces on daily basis. The paper introduction, the conflict in Sudan concentrated in the capital Khartoum has brought a volatile state characterized by chaotic armed attacks impacting millions. The healthcare system is near collapse, with over 60% of hospitals in Khartoum out of service due to insecurity, lack of supplies, and destruction. The conflict has prompted local healthcare workers and organizations to provide support, but a lack of coordinating knowledge and expertise hampers effort. International collaborators are providing resources and training, but an overall emergency medicine network is lacking. My colleague Hamdi will continue to talk about our paper, starting with the case presentation.
Thank you, Dr. Ahmed, for the brief presentation. And thank you all, colleague, and our guest speaker, Dr. Ayman, for having you in this journal club. I am Dr. Hamdi Abdullah Abdurrahman, graduate from the Royal Islamic University. Today I will be presenting the case side of this journal club. So our case is 10 years old child presented to Bashar Clinic in Khartoum after being caught in crossfire. He has a gunshot wound to the chest and the brain, and that there's also skull fracture. The clinic has limited supply, including no blood product, intermittent electricity, and a single overworked surgeon. Imagine that you're working in this situation in Sudan at the moment. How do you manage this patient in this environment? I would like to open the floor for anyone of our participants who want to share his thought about this situation, this case. So the floor is open. If anyone who wants to share his opinion about this case is happy, or even write a comment in the chat. So next, please. as you see, this is a picture demonstrate the case that we talk about. Have chest bullet and actually also skull fracture. In terms of my questions, in a simple way, we can able to say that we will start with ABCs, which is emergency management protocols, by applying the ABC's principle, airway, breathing, and circulation, and prioritizing if in terms of breathing if there's potent airway, and in terms of circulation if there's any blood or active bleeding, try to brace and putting compression. And then you need also to assess the situation. Maybe there's other patient who have the same situation in there, and you have the lack of supply. You have to prioritize which patient you are going to deal. But in this case, this is a very important since you start ministry by the airway. Next, please. So, what are the immediate priority in this case? As I mentioned, would be the breathing and airway and circulation. And then what are the resources lacking and how we will compensate it? If anyone want to share?
Maybe we might lack a
Resource.
proper imagery.
Okay, can hear you well. Can you repeat what you say, Dr. Nadar?
You say maybe we might be lacking a proper imaging, and maybe there will be no CT.
Exactly. Most of situation in Sudan as is going on, there is lack of infrastructure, lack of availability of electricity. Even if you have machines available, with the intermittent resource will be difficult. So how do you compensate this? It will be difficult, to be honest, but at least we need to prioritize what is need to be intervened, and at the same time to see if there's any blood supply is available. You keep it for the most important priority cases. So what are the ethical consideration in the resource score environment? The resource score environment. If anyone is happy, I can open the floor for other participants also in the chat, or you can open the mic. Feel free to open the mic.
I would probably say that it could be allocating resources between patients, like especially with conflict-related trauma. There is usually mass injuries. You don't get one patient, like you said. You get multiple patients, tens, maybe 50s even. How do you allocate resources between them? That would be an ethical consideration.
You're right, absolutely. In terms of this situation, we have a consideration of the resources, and maybe we need also to be transparent with the patient and the colleague that we are working in a dire situation. We have limited resource. You have to be open and consult the patient, make a proper consultation for the patient regarding the situation. And also to be good if you can able to provide emotional support for the patient and their families, that will help this situation. So next, please. Thank you for your sharing the comment. So our paper, as my colleague Ahmed mentioned, is a letter that dealing with conflict and study that address the current conflict in Sudan. And we try to apply the BICO framework in our critical appraisal. As you all know, BICO is an abbreviation for Population Intervention Comparison and Outcome. So the paper targets the population in armed affected communities mostly in Sudan. And the intervention is the implementing of critical emergency medicine resuscitation and trauma education and training program. The paper is that the comparison between limited resource versus structured education and training program. And the intended outcome of the paper was to improve the surgical survival rate and better patient outcome and increase the capacity of healthcare provider, a more resilient healthcare system in Sudan. Next, please. Our selection criteria for this paper was applied in terms of our missions in Sudanese Consortium for Surgical Development to provide accessible and affordable quality surgical education in terms of service and training, and including the emergency medical and emergency critical care and trauma surgery services. And the second selection criteria is the timelines of the published paper that is published during the conflict. And our theme for this month is conflict within and surgery within the conflict in Sudan. So we select this paper based on this criteria. And the third criteria is that it has to be published in a peer review journal. As my colleague mentioned, it was published in the European Journal of Emergency Medicine and Trauma Surgery, and another also another well-known published in well-known peer review. And next, please. The paper demonstration in terms of the study design, it is letter to editor, so it does not have a formal study design. It's based on the our author and his colleague experience and expertise. So the key finding for this paper is mainly the collapse of healthcare system in Sudan and the lack of resources and the need for training, especially in terms of critical emergency medicine, resuscitation, and trauma surgery, and the possible multi-phases rehabilitation strategy that we can implement in order to improve our healthcare system in Sudan. Next, please. Comparison to the other literature, actually there is a less literature published in terms of conflict in Sudan, but there is one have a broader perspective in Africa, which we found that there is a paper with title Emergency Care in Post-Conflict Setting, a systematic literature review by Killenwell and his colleague. And next, please. We found that there is some similarities and difference between our paper and other paper. Yes, please. If there is anyone share, Dr. Asma. So, in terms of the similarity with our paper, both paper it's focusing on addressing the emergency medicine in Sudan, and they focus on the conflict setting. And also, both papers highlight the systematic issue that's going on. And both papers highlight the importance of training, and they publicly agree on the importance of healthcare training and provide affordable training for healthcare professionals who are working in a conflict settings. And also the emphasis on the resource constraint. And the both paper, they highlight this point clearly, and they said that care is often provided in environment with limited resource, necessitate creative solutions, like provide open access environment. One of the cases mentioned this, and the availability of affordable education for the healthcare provider working in the dire situation. Next, please. So in terms of difference, our paper is really focused on the critical conflict that's happening in Sudan. And we need to provide a bit education and training initiative, specifically to the current situation, while the Killen paper is a systematic review and provide a broader perspective on emergency care in a post-conflict setting, and it looks at the longer-term challenges and the strategies that can provide to improve the healthcare system across the system level. So in terms of study design and methodology, as we mentioned, our paper is based on their experience and it's observational. And while the other paper is a systematic review and it have a defined strategies and inclusive criteria. And in terms of the context, Mr. Nasser paper focused specifically on the ongoing conflict in Sudan, and the other paper examined the broader context of the emergency care in aftermath of conflict and addressing the long-term recovery and system building. So they both highlight the need for intervention during the conflict situation and how we can improve the healthcare system in this challenging environment. Next, please. So in summary for our paper demonstrated that the Sudanese healthcare system is overwhelming, as we all know, by the ongoing conflict. And there is also critical need for immediate training in emergency care, resuscitation, and trauma management for both healthcare professionals and lay people in terms of providing first aid and providing HLAs or trauma management system specific training targeting those healthcare profession. And also the paper clearly state that we need international collaboration and provide and provision of and open access education resource and essential to address the crisis in the future. So that's all about our paper. And in summary, if anyone who have comment or questions, the floor, feel free to participate in this.
Thank you, Dr. Hamdi. If anyone have any comment on the presentation of the paper, please open your mic and ask.
الصوت ما واضح. طيب يا أحمد، الصوت ما واضح، ممكن لو في طريقة تتكلم من غير سماعة.
لا واضح.
واضح، أوكي تمام. لو في زول عنده سؤال أي استفسار أو أي comment about the paper, floor is open for you.
Mr. Rayman, can you share with us your insights about this paper?
السلام عليكم ورحمة الله جميعا. I'm not sure, do you want me to speak in English or in Arabic or a mixture of both?
Feel free يا مستر عربي إنجليزي.
تمام طيب. Number one, I'd like to congratulate you for this effort. That's really a great effort. And I really like the approach of looking at the paper and selecting papers that reflect the trouble in our homeland, Sudan. I'm going to start where you started the presentation. That's a 10 years old boy with a bullet in the head and a bullet in the right chest. Just looking at the x-rays, and for the record, for pediatric trauma, CT scan is not the first line of management, and it is not needed as a standard like in adult trauma where you need the pan CT. So these x-rays alone, regardless of the patient clinical condition, defines what we were discussing in our letter to the editor. Because as simple as this, we're talking here about ABCD approach for this pediatric trauma. The first question is, do you have the setup to handle pediatric trauma? We're not talking about a conflict. Let's say, الأمور كلها كانت ماشية very good. That child came to the hospital with this gunshot before April 15th, 2023. Does people in Bashir Hospital have the capacity to handle pediatric trauma? It's always remember, pediatric trauma is not, pediatrics are not small adults. They are different physiology, different anatomy, different approach, and different training. The right size endotracheal tube based on the age and weight. The right side, if you're going to do intubation for this child, most probably are you going to use a rapid sequence intubation? Do you have the medication? Do you know the dose? Do you have the small IV axis? Do you have the calculation for the required fluid? Do you have the calculation for the required blood? And in case, for example, this child went into cardiac arrest, do you have the defibrillator that's going to be adjusted? Do you have the pediatric pedals? Do you have a ventilator setup that's compatible with the child lung and the tide and the pressure there, the ventilation pressure for a child? That's without mentioning the ward. So what we're talking about here is exactly what defined in our paper. When we train, you're going to go for pediatric trauma course and they tell you use this and use that, use the Pritzker chart, and based on that, get the child age and weight and what requirements needed. But in reality, even in our health system in Sudan, that wasn't quite available. Correct? So then the next step is that I'm just going to add a bit of flavor for that scenario. Imagine that that child with the gunshot, they're not even able to reach Bashar. They were in a Sahafa and they were not even. It's just, you remember when the war erupted on Saturday, the 15th of April, there was gunfire everywhere. People are unable even to move from one neighborhood to the other, from one block to the other. Imagine that you are a doctor at your local Hilla or part of Khartoum in a Sahafa, and you're a radiologist, you are a dermatologist, you are an obstetrician, and they brought this child to you because you're a doctor and you have to manage this child. That was exactly the core, the essence of our manuscript and or of this publication. This publication was sent 1 month after the war. It was published 2 months after the eruption of the war. That time, situation was 100 times better than what we have now. And it was a simple letter to the editor with the objectives of number one, medical literature needs to know, people in the medical literature needs to know about the impact of the war in Sudan regarding health service. At that time, people were caught in a lot of difficulties while they're not even able to reach hospitals. It is not a standard war. The Ukraine war has been going on for years. We haven't heard about hospitals who are destroyed or haven't heard about the schools who were destroyed or civilians that they were targeted. So still hospitals functioning, serving civilians. Whatever training you're going to have, ATLS, European Trauma Course, immediate trauma course, pre-hospital trauma course, intermediate, all this type of training based on a certain standard, a certain setup, and a hospital system. That day, all this is gone. No matter how good or fantastic or capable you are, that training cannot take you one step further. Because the training for that setup is only available for military. Only military doctors are capable of taking care of the gunned and the wounded in the field. And they are equipped to provide that. But what happened that day, it's beyond any training that the standard medical services are providing for civilians. And that was exactly the discussion with our colleagues in the European Station Council, in the European Trauma, the ETS, the European Trauma Course Organization, that whatever you're doing, whatever you're providing cannot help. And that was an obvious gap in training. The obvious gap in training is people have to learn to take care of themselves. And it's just too much to ask, even from health professionals at that point. You can't even reach their hospitals. It's too much to ask them to care for like a child like this or a guy with a gunshot in the chest or غيره. Isn't that the situation that it was there? Because at this stage, I'd like to pause and hear from you. Isn't that the problem from the healthcare point of view, regardless of the war and who's on whose side or what's happening or why the war is there? Just isn't that the situation or the problem for healthcare providers on the 15th of April and afterwards? Wasn't that the problem? Wasn't that where we facing? I'd like to hear from you. أنا عايز أسمع منكم ده. هل أنتوا رؤيتكم، هل كان الوضع، هل دي المشكلة اللي كانت فعلا موجودة بغض النظر عن الحرب أو أي سايد، إن أنت كطبيب أو as a medical professional أنت مفروض provide help لقادر تصل المستشفى، ولما تصل المستشفى خلينا من النمبر اوف كيسز الحالات اللي بتجيك beyond the setup available. Was that a problem or
من
not?
بعد يا بص
Yes.
من بعد إذن حضرتك، طيب if it was if it was a gap in the training, how can we fill this gap؟ يعني الميديكال سكولز ما بتفل الجاب دي، الريزدنسي تريننج ما بيفل الجاب دي، الاي تي ال اس والبي ال اس والاشياء دي ما بتفل. طيب يعني what is the kind of knowledge that is only available for the military for the military doctors يعني.
Absolutely right. You know why people in the West did not really think about filling that gap in knowledge؟ هم مشوا beyond that step to teach public and school people. احنا في human resource كنا we go to hospital, to schools, to shopping malls, and we teach the public how to do BLS and how to act in case of cardiac arrest, because they've thought, they've imagined, they are prepared for all kind of emergencies that could occur. And what is the best way to handle it? ولقوا إنه one of the best ways to improve outcome from cardiac arrest, بالذات out of hospital cardiac arrest, which represent more than 60% of cardiac arrest, by the way, إنه to train the public. لأنه you need 6 minutes before you're going to go into permanent brain damage or permanent neurological disability. And in the best hands, in the best centers in Europe, no ambulance could reach you within 6 minutes if you had cardiac arrest. You have a 10% drop in survival rate with every minute passes from cardiac arrest. عشان كده دربوا الناس. But they were not seeing this. They were not seeing that even the worst conflict is going to stop people from going to hospitals and going to prevent doctors from deploying their tasks. They were not seeing this. This is why they did not develop training like this. And this is why we addressed this issue with them. And this is why we wrote this publication. And the publication here, the solution, as you probably read, show it.
أنا فتحت شفتها.
It's toward the end.
يعني هي جات يعني
It's toward the end. And towards the end, the heading, why the conflict Sudan matters to the rest of the world. And that was the important point. The last paragraph says, further efforts should focus on ways to improve the system level approach. What is system level approach? System level approach is like a coordinated, it's like a multidisciplinary team approach. A similar situation comes, for example, during Hajj. اللي هو عشان كده الأخوان في مكة بيقول عليه طب الحشود. They've gone very far away in handling mass casualties and working the system to serve and help as much as possible. احنا هنا ما بنتكلم عن penetrating، كلنا بنتكلم عن blunt injuries in this situation. For example, another example is البريبريشن بيحصل قبال كاس العالم. يعني in Qatar before كاس العالم الأخير they've done more than 110 possible scenarios and drills about all type of injuries, all types of mass trauma and how to handle it. You need a system, you need a drill, you need an emergency plan. So if you ask what is the training required, and we discuss this, we send the same question to our colleagues there, and we send it on When we looked in the literature, the only way to go through that is to have a national emergency plan. لازم يكون في خطة طوارئ قومية. And this is the responsibility of the Ministry of Health. كويس. Ministry of Health in the easy times and the easy days, they put all kind of scenarios زي ما بيحصل مع الفيضان وبشيل البيوت وغيره، زي ما مثلا في كاليفورنيا بيحصل مع الحرائق and so on. بيسألوا how much population do we have? What are the catchment areas? What is the capacity in each hospital? هو ده نفسه السيستم approach. السيستم approach زي ما شفتوا الستبس. And as discussed, number one, the first step is categorization. You categorize what kind of emergencies you expect to face. تمام? And based on this, what kind of hospitals do you have? What capacities? What bed capacity? What sort of training? What sort of specialties موجودة? كويس. Numbers, facilities, equipments, layout. الامرجنسي how could you expand, how could you open words عشان تكون for emergency. لو انت محتاج لمدارس how could you prepare them. لو انت محتاج for example mobile hospitals how could you prepare them. يعني ناس لما مشوا لمدني في فترة كان مشكلة ناس مدني ما كانوا injured and wounded لأنه these are either dead by that time or they're coming with infected wounds. كانت مشكلتهم أكثر الدايباتيك ما لاقي treatment والhypertensive and so on, and they were unable to get them to hospital. فكان suggestion at that time when people spoke, they need a mobile hospital, like a mobile clinic outside who's going to triage and serve these people. And that's going to ease the burden. So this is part of a national plan. You categorize what kind of problems do you have, and then you prioritize these problems. In case of this emergency, what is my priority? What is my target? زي ما عارفين in mass casualty, the paradigm of trauma care is actually inverted. يعني المثلث بتاع التروما كير اللي هو احنا بندي البرايورتي at the top للريد كاتيجوري او الريد تراياد. Excuse me, whom by definition compromise in A or B or C, compromise in airway, breathing or circulation, they get a red tag and they have the priority. Any one of them. When you have a mass casualty, this paradigm is reversed. And the priority here for those who have a higher chance of survival. So this kind of prioritization, this kind of training, that's the second step, and that's part again of the international emergency plan or the national emergency plan that you need to have. And you train people, and you do drills over and over. كل مرة drill في استاد, drill in a shopping mall, drill out in the woods, drill out in the street, and you repeat these scenarios, different possibilities, and what people need to do. Where do they have to report? And what is your task when you arrive? حتى داخل المستشفيات there is emergency plan. And then the third step is coordination. After you assess your resources, your capacities, your expected emergencies, then you prioritize how could you serve and who gets the priority. Then the next step is you coordinate all that work. لأنه هيكون عندك شرطة وهيكون عندك emergency services زي الهلال الأحمر أو الأمبولانس اللي بيجيب المرضى. هيكون عندك داخل المستشفى expansion, how many ICU bed, how many critical patient or ventilated patient you could accommodate, how many scans you could run, how many operating rooms you could run, and based on that you coordinate الكلام ده كله. When the patient arrives, if the patient is or the victim is code red or is a category red, how is he going to be fast tracked and assessed and given priorities in OR, for example, when needed? And then the last step here comes in the implementation of all of that. You implement it, you run it, you look for flaws and deficiencies, and then you go back again, fix, and go again and run another drill and try it. So that's a very long answer to what is the solution in training. Solution in training, we're not going to train people in military. And we're not, that training gap was created because people couldn't imagine that even in the worst war scenarios, doctors and hospitals will be attacked. عشان كده you were not trained for that. But the training has to come within an emergency plan. So أنا ما عايز أطول الكلام, and I wanted just to give you an overview about what was the paper about. It was a letter to the editor. It was sending a strong message that we're crying loud and out in Sudan about the situation. وكلنا عارفين at that time it was way better than what's the situation now. And would like to alert people that we need this kind of training. هم فتحوا الويب سايتس بتاعتهم about this service, about how to take care of patients زي ما قلت زي pediatric trauma دي, different aspects in war time and conflicts. فكمان كانت المشكلة there's no internet, and even people who are in Bashir hospital at that time with that child, if they wanted to Google or check or go to the internet and find out, there was no internet. فit was a complex situation. ما عندها حل. ما في حل إن إحنا نقول إنه يبقى في صراع فوضوي attacking civilians and doctors, وإحنا الحل يكون كده. You are at risk of yourself. وإحنا in the journal عندنا 2 more publications وكنا حريصين over and over with time interval to reflect and remind people about the impact of the war in Sudan. على الريسيرش, وعندنا publication بالكلام ده, وعلى البيرن اوت بتاع الأطباء نفسهم. ف the short answer is that it has to be a national emergency plan built on the system approach, the 4 steps. That's so far my input to زي ما نقول the floor is back to you.
sorry again دكتور, بس if I may, regarding الحتة بتاعت الهيلث بروموشن, أنا تقريبا كأني فهمت إجابة حضرتك في 3 نواحي أساسية في accessibility to the health care أو to the surgical care. ممكن حاجة تتحل عبر السيرجيكال يونتس أو الميديكال يونتس الموبايل عموما, والتريننج ونقطة بتاعت الهيلث بروموشن. بس في سؤال حضرتك في النقطة دي, في الهيلث بروموشن يا دكتور, احنا الآن أنا شايف إنه في مشكلة كبيرة احنا بنواجهها, حاجز يمكن بين المجتمع الطبي وبين بين الناس نفسهم, انه we cannot, يعني ما قادرين نوصل المعلومة كويس للمجتمع. we cannot promote the health بشكل كويس, يعني سواء الحاجة دي كانت إما عدم اهتمام من الإنسان نفسه في المجتمع, أو يمكن طريقة التوصيل بتاعته غلط, أو المكان اللي إحنا بنستخدمه فيه غلط. يعني بناء على تجربتنا إحنا في الكليات لما كنا طلاب, يعني كنا بنمشي بس سواء في القرى أو في الأسر, بتكون حاجات بدائية جدا, بوسترات بتعلق, أنا أزعم إنه استفادة المجتمع منها قليلة جدا يعني. فالهيلث بروموشن did not turn into reality, والمجتمع ما عارف أي حاجة صراحة عن الكلام اللي إحنا بنتكلم لهم فيه يعني. how do you think this is a part of the problem, وكيف ممكن نحلها if it's relevant to the discussion يعني.
Well, that's a good question. And talking about international experience and local regional experience, I'm going to give you a parallel example. Basic life support was introduced, for example, in Saudi Arabia since 1975. Was introduced in Egypt and in Sudan as a concept in 2000 and 2001, 2002. Human Sudan Station Council were the first to introduce basic life support to medical and dental student final year in 2013 and 2014. It wasn't part of the curriculum. كويس, احنا هنا بنتكلم عن دكاترة هيتخرجوا and it's not part of their curriculum to know basic life support. كويس. Even in the Middle East, even in the Gulf area, even in the MENA area, with the huge input of basic life support training and courses, national, international courses, still there is no unified consensus on how do you approach a patient in cardiac arrest. There is no national consensus at all. There is no regional consensus. While in Europe, there is a national consensus. There is a regional consensus. There is even one telephone number for emergency service SCSD بيعمم to more than 18 countries in Europe, and it's expanding. The effort to engage public has to be national, has to be part of government's commitment. وعلشان كده في الميدل ايست والعرب طبعا قلوبهم شتى. برغم من ده كله بتلقى انه in one country تلقى one hospital running American BLS, one hospital running European BLS, one hospital running Australian, one hospital within the same country are running even their own national basic life support. وعليه التريننج وعليه الاكريديتيشن وعليه كله. نقيس على ذلك. You don't have a national consensus and we do not have a regional consensus. If you don't have this, how could you have consensus that to tell public you need to learn about that? Nevertheless, the input from public has came a long way. وزي ما قلت هي كانت طرق بدائيه لكن it's an effort. الناس حتى في القرى اللي بتمشوا، احنا من ما كنا في الجامعه more than 20 years ago كنا بنمشي في القرى بحملات علاجيه وبتديهم ادويه وكله حملات توعيه، وبيقولوا دير ما طلبت الطب جونا وتكلموا لنا عن كده، او يعني it is still ring a bell. كويس. لكن بيبقى methods of training the public, methods of public awareness. It has to be systematic. You have to approach الناس اللي هم الكي هولدرز. علشان كده الناس اللي الببليك بيسمعوا لهم. European Station Council is starting a campaign about cardiac arrest training in conjunction مع اليويفا Champion League. جايبين هالاند وجايبين روديجير وجايبين مبابي وجايبين الناس ديل كلهم بيعلمون بيزك لايف سبورت. علشان ديل الببليك بيسمعوا لهم. يبقى you have to use all the possible methods to attract public and let them know that that's an important part. And you have to continue and run, but you have to have a national support للكلام. So the answer, the effort is there. It is not ringing a bell to the public. If the method is correct and the outcome is different, then change the method. Because at the end of the day, you can't repeating the same thing over and over. You have to find a way to reach the public. Even now with first aid. يعني مجرد انه الببليك يعرف الساينز of life threatening bleeding، يعرف ازاي يتعامل مع peripheral bleeding، يعرفوا arterial venous how to apply pressure. Excuse me. These skills need to be reached to the public. This has to be part of the commitment. لو أنا قلت إنه ما في security مول أو ما في بياع في مول أو سواق حافلة أو كمساري أو military personnel أو أي زول شغال مع public أو موظف في بنك كويس، لازم يكون عارف كيف يتعامل يعمل BLS، ولازم يكون عارف يعمل first aid. That's going to be part of your recruitment and they are available even online. كويس. then you are advocating this to the public. لأنه كل شخص من ديل هو شخص مؤثر في المجتمع بتاعه. Go to the school teachers، أئمة المساجد. The people that public listen to them. That's one way to approach it.
Okay, thanks, Mr. There is another question from Dr. Baha. He said, Dr. Ayman, many thanks. How has the response from the international medical and humanitarian communities been since the article's publication?
طبعا thank you very much again. That's a very good question. And when you make a statement, you'd like to see what is the response. And I have to admit it was disappointing. لأنه كل الorganizations there were willing actually, they opened their access, بقى free access عن طريق الويب سايت بتاع Human Resources. If you went to the website of Human Resources, you'll be able to click on the controlled material access that they have and prepared for Ukraine. But الobstacles كانت انه ما في انترنت موجوده في السودان. That's number one. ونمبر 2 انه that's only provided access للناس علشان يقدروا to educate themselves and they learn. A lot of people, a lot of police كانوا شغالين. ناس سامة for example كانوا بيحاولوا انه يأهلوا بعض المستشفيات في الكاملين وغيره، ولكن الانسكيورتي جات عليهم ودفرتهم and so on. في بحري في جزيرة مستشفى مدني people who were trying to uplift عدد كبير من الزملاء مشكورين مشوا المستشفى مدني they start to provide the service. بقى عندهم مشكلة بتاعت limitation في السبلايز. supplies وصلت لبورسودان for a reason other ما وصلت مدني. you can tell it's a chain reaction، يعني كمية من المشاكل كلها مربوطة ببعض. and without an emergency plan this cannot work. احنا بنتكلم هنا عن conflict respect hospitals and doctors. لما بيحصل بتتفتح emergency plan طوالي، بيكون في lifeline or open passages للorganizations international and national organizations عشان توصل السبلاي. بيدوك كيت كامله، الكيت دي عباره عن لابروتومي سيت ديسبوزبل كله، بيدوك منها 20 و30 و50 سنت عشان تقدر تشتغل. بيدوك all kind of splints اللي انت محتاجه للفراكشرز and so on. بيديك السبلايز دي، لكن السبلايز دي بتصل بورسودان وما بتصل للحتات الدارينها for a lot of reasons. كويس. التريننج بتاع الناس to use this supplies بتجي بالكتالوج، بتجي هنا هم ناس نفسهم محتاجين انه يجوا and to train people. European Trauma Course Organization مشوا يوكرين under the control of the United Nations ودربوا الناس on the European Trauma Course. People في المستشفيات في غزة are doing great job. They are well capable surgeons than you could imagine. الكونفليكت في اليمن نفس الحكاية، بتمشي حملات وبيمشوا دكاترة and they go and serve taking equipments. فيبقى انت your problem انه the international community responded either by open access, by providing, by asking how could we help, or by bringing aids لحد بورسودان. and there are people on the ground. عدد كبير جدا من الزملاء انت عارفين اكثر مني انه وصلوا مدني وهسه موجودين في حضبره وغيره. لكن it is not only a matter of problem of manpower only and training، لكن manpower training and supplies. فدي why it's complex. وده كله تاني لو رجعنا انه في emergency plan بتحدد the prioritization the category of the need you want the priority بتاعت النيد دي and then how you deploy a need that and how you coordinate it, there will be a response. لكن when even people trying to respond and it reach the ground and then it reach an end point وما بتوصل where it is needed, then no matter what you do it's not going to change. ده كان التشالنج اللي حصل حتى في للناس اللي مشوا، الناس قعدوا في مدني شهور وشهور willing to provide service.
Okay, there is another question, but we will keep it for to the end of the session because we still have presenters to present their parts. I think this could be, we would like to manage our time more better. So my colleague Mariam Rashad will present the study design strengths and weakness, and we will return to your questions بهادين إن شاء الله.
Okay. Thank you, yeah, Ahmed. يعني to be here in this journal club. My name is Mariam Rashad. I'm 6-year medical SCSD research officer. I will proceed talking about strengths and weakness of this paper. Next. So as already mentioned, it's a letter to the editor. So it's an opinion piece regarding the impact of war on Sudan healthcare system and appeal for emergency medical training. It doesn't go like usual studies like observative or so on, as you know. Next. So I will start stating the strengths. It's actually a well-organized paper. First of all, it's timely and relevant. The paper addressed the current humanitarian crisis, calling out Sudan collapsing health system. As already mentioned, it successfully raised the awareness. It's meant to raise an awareness on the need for trauma training in conflict area, particularly within an environment where 60% of hospitals are not functional. So this is a great paper, like, because of the war at that time was like unseen by the outside. So we need to raise the awareness regarding what's going on. Next. The paper also include international perspective. It involves contribution from number of international organizations, such as European Society for Trauma and Emergency Surgery and European Trauma Course Organization, which adds validity to the argument. The next point, it suggests, as already mentioned, system-level approach. It's proposed systemic step for medical action in war zone, including training, education, mobilization of local communities, and involvement of doctors. Next. The author also suggests a three-phase intervention plan as a multi-phase approach addressing the crisis. It's also identified the role of emergency medicine, anesthesiology, surgery, and international trauma education program, which help to use of interdisciplinary collaboration of various departments, managing the situation and in the conflict area. Next. Okay, regarding the weakness, so because it's a letter of the editor, it's like empirical data. It's like original research data like patient outcomes, mortality rate, quantitative evidence of the impact of intervention carried out, and so on. The next point is the limited critical analysis. While the paper describes initiatives, it's like a critical evaluation of their effectiveness. It does not, for example, quantify if online training material improve clinical competency or patient survival rate, because it may be because of the limitation of the paper. There was no internet connection and so on. Next. The next point is there is no comparative analysis. The article reports that the same strategy was utilized in Ukraine, but does not provide a comparison to the efficacy of this intervention in different conflict zones. The next point is a lack of specific implementation details. Even so, proposing solutions, there was hardly any mention of logistical details such as security issue, resource allocation, or sustainability of this intervention in the future. Next, please. The next point is limited critical analysis. The paper describes project. It does not have critical evaluation of how successful they have been. It does not, for example, measure whether the clinical competence or survival of patient improved due to the utilization of online training resource, and so on. The last point, if there is no ethical or cultural implication, there is no mention made of the ethical implication of training non-professionals for trauma care in war setting, or whether or not cultural implication influence the application of trauma training based on Western concept. It just suggests using of part of online material for education and training, but it didn't emphasize on the need for cultural implication to suit for the cultural difference between the communities. Next. That was a brief review about the strengths and weakness of the paper. I would like to open the floor if there's anyone have question or addition.
I think we have to let the questions for the end. We will continue to the relevance and reliability section with our
Uh, Assalamu alaikum. My name is Aw, an SCSD fellow, and I will talk about research relevance and reality. One second. طيب. Why this study matters؟ ليه البيبرز دي مهمة؟ This research is crucial. As Sudan conflict has crippled healthcare, leaving hospital non-functional and medical workers overwhelmed, the study highlights the urgent needs for emergency training in such crises. It also addresses the urgent global health issues such as medical response in war zones, discusses lessons from international disaster response, comparing Sudan to Ukraine, provide a framework for training and resource allocation in crisis settings. In broader implications beyond Sudan, this finding can be applied to other war-torn regions facing similar healthcare system collapse, emphasizes the need for international collaboration in crisis medical education, encourages a system-level approach to emergency medical training in low-resource settings, and also it advocates for policy changes, to support healthcare worker in conflict zone. The reliability of this research ممكن نقسمها ل strengths and limitation. The strengths إنه this paper is authored by experts in trauma and emergency medicine, cite credible resource like the UN, the WHO, a European trauma course, and it also discusses real-world cases, studies, and international collaborations. The limitation, as my colleague Mariam also mentioned, because it's a letter to the editor format, lacking primary data and statistical analysis, limited data on the effectiveness of emergency medical training in war zones, and potential for bias as it advocates for increased training and funding. Next, we will go with my colleague Alap to discuss the research gap and future directions. Thank you so much.
Hello, hope you can hear me. I will talk about the research gap in this paper, but more importantly, the research gap in the field of critical emergency medicine and trauma surgery to focus on the broader aspect. So next, please. So the gaps in the field of critical emergency medicine and trauma surgery is really a huge gap, as previously mentioned by my colleagues. The first area is the lack of data. So we all know the fragile health information system in Sudan before and even worse than after the war. So there is a lack of empirical data, and there is a lack of actual measurement of improvement in terms of patient survival rates and improvement in patient outcomes. So the limited data is the first thing. Then there is insufficient discussion on barriers to implementation. So this paper suggests introducing trauma education and training in conflict zone. But the broader gap is barriers to implementation, such as infrastructure destruction. So more than 70% of health facilities in Sudan are out of service, let alone the medical schools and all the forms of medical treatment. So the huge destruction form a barrier to implementation to these training models. Next is the shortage of qualified instructors and the lack of security and instability also is a barrier to implementation. Next is the deficiency of localized training model. So this study heavily references international organization, but it lacks insights onto Sudan-specific training models. So as Mr. Ayman previously mentioned, there is a kind of lack of system-level approach and national or regional guidelines and concerns on the training education, on the trauma education, and also their integration with the local health system. So in a setting of a fragile situation in Sudan, and it is been a war zone for a lot of years. So such things should be actually integrated with the local health system. Next, please. So next is the absence of patient-centered outcome. The paper does not examine how current trauma education initiative impact patient outcomes in terms of morbidity or mortality measures, or in other forms of patient improvement in outcomes. So just give me 1 minute. Really sorry for the interruption. So I was talking about the absence of patient-centered outcomes. In order to say this training model is effective, we need to have an actual measurement in terms of improvement in patient outcomes. So there is limited data regarding this. Also, there is limited focus on long-term sustainability. The paper emphasizes an immediate emergency response strategy, but it does not discuss long-term sustainability. And in terms of sustainability, we need to talk about measures of monitoring and evaluation, especially economic evaluation. So the huge economic burden put even a lot of challenges to the health system. So measures to monitor and evaluate the economic burden is really a gap. And finally, the comparative studies, not only in terms of comparing the training models to themselves, but the training in similar regions, similar situation, and so on. Next, please. So next is the limited focus on gender-specific challenges. So the article does not address gender disparities in access to emergency medical training. Female health workers in Sudan may face unique barriers to participation, such as security risk and gender-based violence, rape, cultural restrictions, and lack of mentorship. The impact of gender-sensitive training approach in conflict settings remain unexplored. And next is the need for pediatric and geriatric trauma care consideration. So as Mr. Ayman previously in the beginning of our talk highlighted the differences between pediatric trauma and also geriatric trauma. So training models should be tailored to different genders and different age groups. Then is the mental health and psychological readiness. How does training impact psychological resilience among frontline medical providers, and what mental interventions should be incorporated into training programs? So with this huge stress comes burnout and fatigue of healthcare providers. So training models should also include some form of training on how to be resilient and how to fight burnout in such volatile settings. And finally is the ethical consideration in international humanitarian law. The article touches on the lack of adherence to international humanitarian law, but it does not explore its legal and ethical implication in depth. For example, are there research framework that could ensure medical personnel safety, and how can international organization hold armed group accountable for targeting healthcare facilities? So we know all the lack of adherence to the international humanitarian law, and this is not a new challenge to Sudan. Healthcare workers have been targeted by armed groups since long time ago, and this lack of adherence to international humanitarian law may also form a barrier to implementing an effective training in Sudan. Next, please. So all the previous points I mentioned are some gaps in the broader field, but still a lot of questions exist and a lot of gaps. This slide is mainly about further questions. As you can see, the slide is busy with a lot of questions. I will read them, then we will leave a few minutes for discussion. So as to provide your experience and your thoughts on whatever as you like. So I try to group the question into 5 groups. One focus on manpower, one focus on the sustainability and long-term resilience, and the third focus on different training models and the incorporation of telemedicine and VR AI-based simulation models. And the fourth category focus on financial barriers, and the last focus on policies and Sudanese institutions. So in terms of the manpower, the first question is there differences between trained and untrained Sudanese healthcare workers? And the second question is the incorporation of traditional healers and community members in these training models. It specifically the ethical challenges of incorporating the public in training models. Previously, Mr. Ayman also already mentioned the significance and importance of involving the public in trauma education and critical emergency medicine. But are there any ethical challenges since there is no regional or national consensus and agreement on what guidelines to apply? This focus on the manpower. The second is about the long-term resilience and sustainability. And with sustainability comes the measurement of effectiveness and continuous evaluation and monitoring. So we need to address what exact metrics to use to evaluate the success and effectiveness, and how to standardize data collection in a setting of a fragile health information system in Sudan. So how to standardize the data collection system in Sudan to have such a baseline to start from after when we reach the recovery period or after the war start. We need to have a standardized data that we can reference. Then the third is incorporation of technology in training models. Telemedicine and virtual reality and AI-based simulation models are they actually effective in such a volatile setting, having all the challenges like internet connections and power sources and so on? What is their effectiveness and how do they compare versus in-person training? And if they are effective, how to incorporate them in the curriculum for long-term sustainability and the future healthcare providers? Then comes the financial barriers, and this is also a broad aspect and need in-depth discussion in terms of availability of fundings from the NGOs, government, and international organizations, and how to allocate resources in most efficient way. And then lastly, the policies, and I think this question is also mentioned previously, so we can discuss on this further. What exact policies that need to be incorporated to the system, and what is the role of Sudanese healthcare institution in these efforts? So all these questions are open for discussion. You can pick what you think you are experienced on or have thoughts on, and the floor is open for discussion.
Okay, if anyone have any ideas and thought to share with us regarding these questions or regarding the previous sections, you can your mic and feel free to.
I just have one comment here that that's a very good systematic appraisal um, to the article. The only thing is that this systematic appraisal does not apply for letter to the editor or short communication. And this is why it is very difficult for people, for the respected presenters who've gone through the appraisal. I could feel how difficult it was to them, because that model of systematic appraisal does not apply regarding letter to editor or short communication. And I'm not sure about the selection of the article itself for the discussion, or the selection of the method of appraisal for the discussion. This is something that needs to be looked at. And but all to all, for the academic exercise of this session, it is good to have a systematic appraisal. It's just it doesn't apply to short communication and letter to editor. That was only the comment regarding the appraisal. I have just another comment about a couple of questions. One of them is how if self-directed learning and its evidence in effectiveness. It is being proven that self-directed learning in basic life support is as adequate with the studies. If you attended a basic life support with the instructor, and you attended a basic life support through a video online, and you came to an instructor who was blinded and run the test, the end of course test on both of you, they found that there is no statistical difference between those who have instructor led and those who have self-directed learning in some studies. So it is proven. The ethical background, there is something called the Samaritan Law, and the Samaritan Law protects public when they provide medical assistance in case of emergency, and it's available in many countries in the world. In the Arab world, it's only available in United Arab Emirates as concept, but not as law, as long as you have proof that you're trained to provide this service. So these are two things to add to the appraisal in relation to how effective is this, if self-directed learning, is it effective or not? Yes, it is. The only thing that you cannot measure is the level of competency of the learner. And unless this learner goes over to have a test at the end and being certified in that skill, that's only being considered as awareness and not not adoption of the skill.
Thank you very much, Dr. Rayman. There's one question here. Dr. Baha is asking what's the most pressing, as the most pressing challenge in providing emergency and trauma care, is it better to initiate a national policy related to the emergency medicine, related to wars, or it's better to be part of a curriculum in the Sudanese Medical Specialization Council, for example? Where should it come from?
There are two ways to approach this. A national emergency policy is a commitment of governments toward their own people. مسؤولية وزارة الصحة إنه يكون عندها national disaster policy. دي مسؤوليات تجاه الناس. If you're working in a facility زي ما بقول لك عندك assembly point and evacuation plan in case of emergency, it's a commitment by law that institutes and Ministry of Health and government should provide to their own people based on the nature of emergency. Now, if it is a science and education and training and a degree, yes, there is master degree in disaster medicine. There are consultants in disaster medicine, and it covers these parts. Yet still, there is no curriculum or course or training for chaotic war conflict as it happened in Sudan. And that was the issue in this publication.
Thank you very much, Doctor.
So yeah, Mr. And I have a question regarding the incorporation of AI and virtual reality in the training. Do you think they are really effective and cost effective and worthy?
I Definitely, Anna, on personal level, AI, you know, that last year people were talking, oh, students are using AI and they shouldn't because that's cheating. And if you're using AI, that's fake. That's totally incorrect. Now we have, as educator, as an university staff, and a person who's involved in examinations, we had 3 workshops about using AI in creating examination, using AI in training. It is part of our life. There is definitely a role for AI in training, even in virtual training, even in virtual scenarios. And if they are to create training, that's my personal opinion. If they are to create training about chaotic war zone scenarios, I think AI is going to be the best way to go for. It could be a sort of hybrid training where you get the material, you learn the skills, and then you get the scenarios. The same like military, how to protect yourself, in addition, how to do a damage control until it reach a facility. So yes, there is a role for AI. I'm not aware how detailed or how feasible is that role, but as a potential, of course, there is.
Also, there is a question from Malik. He said, Dr. Ayman, I read in the article you mentioned that there is no current data on critical emergency care, resuscitation, and trauma management education tailored for extreme conflict conditions. What key metrics or research methodologies would you propose to develop evidence-based training modules for such environments?
Thank you very much for the question. For any project to happen, someone needs to take charge. And to take charge of that, of a project, a training project, it has to come from 2 bodies. If we have the Sudan that we had before the 15th of April, this charge, as I mentioned, falls on 2 parts in the Republic of Sudan, falls on the Ministry of Health, the Federal Ministry of Health, for putting emergency plans and assessing needs and assessing the type of training they need based on the environment and the capacities, because that's their job. They know the hospitals, the capacities, the facilities, and they are the one to provide the equipment, because for any service, you have manpower, you have administration, and you have equipment. Now, for the manpower training, here comes the role of the Sudan Medical Specialization Board. They are the ones who tell them, this is the kind of training that we need. Either they can provide it or they can use the help of international experts. And as I said, the good example is في مكة المكرمة during Hajj time, جامعة جامعة القرى في مكة, they have a master degree in crowd medicine, طب الحشود, and how to flow people, and it reflected on the ground. يعني كل الاكسنس اللي حصلت over the years في رمي الجمرات وفي الحرائق اللي حصلت والتدافع وكده, all this has been addressed scientifically. And there is now the use of technology, even with sensors using the count of people in the flow, من بداية المسار لرمي الجمرات، من خيامات الحجاج لحد ما يوصل للجمرات. There are sensors and counters and smart cameras telling that if the capacity of that passage, say, is 1,000 passers per minute, and over there at the beginning there are 3 or 4,000, then they slow down. They control, they stop them لحد ما يطلعوا ديل علشان ما يحصل crowding at the bottleneck. Yes, it is science, and someone has to take charge of it.
The opportunity now goes to our Chief Visionary Officer, Dr. محمد صادق. محمد الصادق. دكتور محمد الصادق. The opportunity is
السلام
yours to
عليكم.
talk.
سامعني؟
Yes, we can hear you. عليكم السلام.
طيب أنا أول حاجة داير أقول شكرا يا مستر أيمن على الإنسايت العظيم اللي قدمته، وداير أذكرك بالميتنج اللي عملناه في شهر 5 2023. كان أول ما هو الحرب بدأت وكده، أنا قمت رسلت لمستر أيمن واتكلمنا اوفر ميتنج كده بصورة قصيرة وكده، لكن كان الغرض الكبير إنه how can we serve situation بتاع الحرب في السودان، ونحن ك SCSD كيف ممكن نساهم في الحاجة دي. فمستر أيمن من الوقت ده يعني he showed like great enthusiasm in to support the Sudanese development training وكل الحاجات. وحتى لو مذكر يا مستر برضه كان دخلت معاك ناس إدغام، وبدأنا أو بدأت في الفكرة بتاعت إنه تخلي النولج افيلبل للناس، ودي الاكسبيرينس اللي حاسس انت يو ار شوينج وريفلكتنج. طيب نحن من البرسبكتيف بتاعنا في الاس اس دي دايرين برضه نسمع رايك في الواي فورورد بيوند الليفل بتاع السيستم. يعني احنا عارفين انه الريسبونسبيلتي بتاعت وزارتنا في الصحه انها المفروض هي تعمل دورها. يعني احنا كمنظمات يعني voluntary organizations همنا اننا نطور الجراحه والتروما كير في السودان. شنو المفروض نعمله كخطوات عمليه و ways of advocacy تتعامل عشان نخلي الوزارة تتيك الرول بتاع إنها تنشيت البوليسي، وبعد ذاك كلنا نكون شغالين أندر الكفر بتاع أندر الأمبريلا بتاعت البوليسي. و further details بدينا تدسكس الحاجة دي مع بروفيسور إيهاب عن السامة، هو ماسك الدين اوف education. ففي مبادرة بتاعت إنه نحن to initiate initiative that could take الموضوع ده forward. فأنا داير أعرف أسمع رأيك في ideas زي دي. how can we transform ال critical care التروما سيرجري في السودان to a level معين نقدر to promote به، نكون عندنا data نقدر نتكلم بها، ونقدر to convince ال Minister of Health. و يعني سؤال تاني، هل ال human resource مثلا could be part of مبادرة زي دي؟ شكرا لك.
محمد سلام عليكم. It's good to talk to you again. محمد فعلا زي ما قال أنا I really thank you very much for the enthusiasm. بالعكس إحنا at that time you remember our discussion إنه we were all hurting and we were all kind of يعني feeling the pain of what's happening to our beloved country at that time, and that was only a month from the war. وكان بنتكلم what is the way forward, and I think at that point we say كل زول بيقدم بالبيقدر عليه. واحنا with our contacts with human station organization قدرنا نفتح الماتيريال والنولج. اشتغلنا مع جروب، اتعمل برضه جروب let me get the name right، اللي هم جروب ناس دكتورة سارة في يو كي برضه، كانوا عملوا اللي هو للميديكال ستودنت. كانوا عملوا medical students training on how to create online modules and online training. ساعدت عدد من الميديكال ستودنتس. Human Resource since that time كان عندها two missions، لأنه احنا our main mission is training and training and public awareness. Um, كان صعب to provide السيرفيس في السودان، لأنه كل المان باور بتاعنا كان طلع من السودان الوقت ده. Uh, what people don't know that في يوغندا، وهيومن ريسورس اتسجلت في يوغندا برضه هسه، في يوغندا في فوق more than 43,000 registered refugee Sudanese. أقل من نصهم شوية في مقاطعة في شمال غرب يوغندا اسمها كرياندينجو، في مقاطعة بيالي. موجودين في معسكر ظروفهم سيئة جدا جدا، وفي عدد منظمات شغالة معاها، ونحن وصلناهم الحمد لله في المعسكر. قدرنا نشيل اللي بنقدر نشيله معانا علشان نساعدهم. أخذنا معانا عدد كبير من الأطباء والزملاء اللي هم مشوا، قدروا يحلوا جزء من المشاكل، لكن هي زي ما بقولوا نقطة في بحر من حجم الحوجة الموجودة هناك. من ناحية المشاكل الصحية، ناس off their medications diabetic وhypertensive، وناس عندهم heart disease off their medication، ناس عندهم بعض المشاكل just simple physiotherapy advice. واستعنا بعدد كبير جدا من السودانيين داخل يوغندا in the diaspora، ومشوا بيعملوا أيام علاجية لهم عشان يوفروا، لأنه it takes you 4.5 to 5 hours عشان تطلع من المعسكر تصل كمبالة بس تلقى العلاج. ف the window for help is there. عملنا موديولز اونلاين، موديول تريننج للدكاتره الموجودين هناك، وداخل المعسكر في 75 طبيب of different levels هم لاجئين وداخل المعسكر وبيقدموا الخدمه. واتكلمنا معاهم عملنا لهم training about the first aid and about the stopping the bleeding, about assessment of wound and wound dressing and wound care علشان يوفروا على الناس المشيه، بالاضافه طبعا للبيزك لايف سبورت تريننج. ف the window to reach الناس هناك human resource دلوقتي عندها الكاباسيتي to reach people اللي هم السودانيز refugees في اوغندا. داخل السودان زي ما وريتك معظم الستيشن كان عندنا ستيشن في مدني، ومع الاسف did not last بعد ما حصل في مدني. What we can work with انه احنا we're definitely willing to participate, willing to support, willing to provide our connections and our website and our educational facility to spread the knowledge. حتى مع contacts عندنا good contacts all over the world, good expertise whether with through seminars, webinars, Zoom meetings, direct training, online training modules, hybrid training. كل الكلام ده is feasible لو قدرنا نوسع دائرة انتشار المعلومة. ف you remember احنا ودiscuss الكلام ده قبل كده يا محمد، قلنا كل زول يمشي في زي ما بيقولوا يحاول يمشي بالدايركشن بتاعه. إيهاب
يس.
طراو طبعا is my classmate و he's doing a fantastic job، سواء كان في جوبا أو هسه دي بالانيشيتيف العاملة.
ايوه.
ستيل تاني بعيدة، احنا we're willing to cooperate كل زول بيقدر عليه.
100%. طيب خلاص، ده كلام جميل جدا جدا. احنا we have reached في الليفل بتاع الستودنتس، في الميديكال اوفيسرز، الليفل بتاع الريجسترارز اون فيلد في السودان. وزي ما قلت بالكونكشنز بتاعتكم بالماتيريال بالاكسبرتيز we can build a huge network of knowledge spreading pathways. ف I'm happy that you are still taking الانيشيتيف دي forward و taking ال السبريت بتاع ال spreading of knowledge و provide the support. اوكي I will reach out to you بديتيلز، وبعدك نشوف how we can push الموضوع ده forward. فبرضه من هنا داير تو اناونس الموضوع ده فورورد عشان الناس نمشي طوالي براكتيكال. اي واحد من الشباب اللي قاعدين في البلاتفورم الحالي حتى لو ما من الاس سي اس دي willing to be part of الانيشيتيف بتاعت التروما والكريتيكال كير سيرجري ديفلوبمنت في السودان. send a message to أحمد أمير هسه حاليا، بس في الشات بالرقم الكونتاكت بتاعك أو الإيميل بتاعك. آه،
تمام. I'm going
أنا
to write my اتفضل. I'm going to write الايميل بتاع الكونتاكت ايميل بتاعنا، و based on this احنا حتى اللينك to the website اللي
yes
بتقدروا تلقوا فيها يعني المعلومات coming one after the other.
perfect perfect I'll reach out definitely. معانا مس عبير برضو هنا، لو في طريقة مس عبير لو عندك أي بوينت لا تضيفيها بس على الاكسبيرينس بتاعتك برضو في الشغل في السودان و ideas of ways forward. طيب أحمد عمير، في أي further points you want to raise، أي plans إضافية للدiscussion for today؟
I think just take away messages.
مم.
Uh, Alak can continue say it.
So, lastly, we will conclude our discussion with some recommendations and conclusions. So, the recommendation for future research on improving the area of trauma education in Sudan. First is to conduct large-scale and data-driven studies on training effectiveness, to have localized training models, and to develop Sudan-specific trauma training models by local institutions with international support, to address vulnerable groups, incorporate gender-sensitive, age-specific protocols and mental health into training curricula, to test and integrate technology-enhanced education models in war zones. So we need to pilot VR and AI-based simulation and telemedicine to enhance training in resource-limited areas. And importantly, to have continuous evaluation and monitoring with specific metrics to measure the cost effectiveness of these training models, and to have a sustainable funding. We need to explore hybrid funding from the government, NGOs, and international aid. And the conclusions are that this studies raise important points but lack empirical depth. Several unexplored research areas could improve trauma education in conflict zone. Future studies should focus on localized, sustainable, and measurable interventions. Long-term sustainability require integration with local health system and multidisciplinary efforts. Trauma education initiative can reduce mortality in conflict zone, particularly for severely injured patients. And finally, there is urgent call for collaboration between local and international organizations to bridge these gaps. Thank you very much.
أحمد أنت on mute if you are talking.
I think I didn't hear Alak completing her.
She finished. Probably your internet is a bit fluctuating maybe، لكن هي خلصت الكلام بتاعها و because she highlighted the very nice points.
Okay. I think there is a feedback form in the comments. Feel free to fill it. If anyone have any questions or comments to say regarding this journal club, we are happy to hear from you.
انا داير اقول لكم شكرا، يعني شكرا للريسيرش ديبارتمنت، شكرا للاوفيسرز في الريسيرش ديبارتمنتس، للليدرشيب، للفيلوز في الاس سي اس دي، وشكرا للضيوف اللي معانا برضو. شكرا مستر أيمن. الانفايرمنت اللي انتوا بديتوا تكونوها في الانفايرمنت بتاع الدسكشن about الريسيرش ولا الاويرنس about الريسيرش is حاجة very vital for the development بتاع الساينس والنوليدج والايفيدنس بيست practice. و I would like to applaud you all يعني الايفورت اللي بتعملوا فيه كل شهر. ودايرين برضو نجدد الانفيتيشن لمستر ايمن. كل شهر احنا مستر عندنا جورنال كلاب بيكون بالطريقة دي we discuss one of الارتكلز اللي بتهم شان السودان. most of the time لحد هسه كل الارتكلز كانت في theme related للسيرجري والكونفليكت في السودان. فنحن we'll invite you ونتشرف بوجودك معنا وبالكومنتس وبرأيك في كل الاستاديز اللي بتتناقش هنا. فافتكر دي بس يعني بداية نحن بديناها هسه الشهر الثالث ولا الرابع يا شباب. فافتكر دي بداية ممتازة ونحن نواصل فيها. و I would like to thank you كلكم الإفورت اللي بتعملوا فيه ده. وإن شاء الله يعني نواصل ونقدر to make a change يعني. Thank you very much.
شكرا جزيلا لكم. I'll be happy to join every month. ولو وريتونا الثيم I could recommend some of my colleagues برضو. موفقين بإذن الله و it's a pleasure to be with you today. شكرا جزيلا. في أمان الله.
Thank you, Mr. Ayman. Thank you for your precious time and advices. Thank you all to our colleagues, our fellows, and everyone who is interested in lifting up the burden from our families and people in Sudan during this catastrophic conflict. Hope to see you next journal clubs. Thank you all.
شكرا لكم يا شباب. دي فقرة الميتنج. ما بعد الميتنج يدور عنده أي بيرنينج بوينت داري يناقشها في الفري
Uh,
ديسكشن ما بعد الديسكشنز. حمدي you are on mute. هنا جو راجعين قاعدين للديسكشن ما بعد الديسكشن.
مرحبا بكم الناس مسكين، لكن صراحة الموضوع جرى
شنو؟
موضوع جديد
يعني احنا كنا في انترفيو ميتنج مع إلاف.
بالله.
كويس.
عشان كده قاعد خدت ايميل الريسيرش نظام انا والريسيرش مع بعض نثبت الشباب ديل سوا. الله يعلمين.
احفظ الكوبي رايت.
أول حاجة قبل ما تبدأ الميتنج الثاني I would like to stop the